Healthy Conversations is made possible through a grant from the William L. and Ruth T. Pendleton Memorial Fund.
Good morning. My presentation here today is about total knee replacements, okay? And how do you know when it's time for a total knee, all right? Let's go into that. First of all, who am I? My name is Dr. Francisco Jaume. I'm in charge of orthopedics at the hospital, and I've been here in the community for 18 years. I've been doing this for 28 years. And my interests are total knees, total hips, and also I'm a general orthopedist, so I do a lot of trauma work. I do open reduction, internal fixations of ankle fractures, knee fractures, wrist fractures, forearm fractures. In my training in Philadelphia 28 years ago, we covered all aspects of orthopedics at that time. So I consider myself a general orthopedist with multiple interests. Now, what got me involved in orthopedics? Well, I was 14 years old. I was a pretty good basketball player, soccer player, and baseball player. So I abused my body a little bit too much, too young, and I tore my ACL playing soccer. And so my first encounter with orthopedic surgeons it was a night game. I'm from North Jersey, so we were playing Essex Catholic, which is a big Catholic school in Newark, New Jersey. And I went to Harrison High, and we were state champs every year that I was in high school. From 1970 to 1974. Well, this was 1970. I'm a freshman playing varsity, and this young man from Essex Catholic put a move on me, and I twisted my knee, and I couldn't straighten my knee out. I was in a panic. I thought I was crippled. I could not straighten my knee out. So they carried me off the field in a chair, right to the emergency room. So what I had was a bucket-handled tear or a meniscal tear of my knee, which was flipped, and I couldn't straighten my leg out. And in addition to that, I tore my ACL. Well, this is 1970. So at the hospital, they reduced my knee, and in other words, they flipped my meniscus back the way it should be so I could straighten my leg out. And I was placed in a cylindrical cast for about 6 weeks. And that was the treatment back then. So that has been my experience with orthopedic surgeons. And what I liked about it is we're basically, you come to my office, you have a situation, an injury, I can fix this injury, and then you're good to go. You can go back to your normal activities. So I found that very enticing when I went to medical school, and that's why I went into orthopedics. So enough about me. Let's take a look here at our next. So we need to know the knee, okay? I mentioned a lot of structures, and I guess I should have mentioned them after we went over what a native knee looks like, okay? So of course we have the bones, which is the distal femur and the proximal tibia make up the knee joint, in addition to soft tissue like the meniscus. The meniscus are these structures that are on the inside part of your knee and on the outside part of your knee, and they cushion your knee because the knee is one of the biggest joint in the body, and it has to put up with a lot of stress. As you know, when we walk, when we run, when we bicycle ride, the knees are always going. So all these structures are very important to keep the knee in good congruity, okay? And then what happens is if you have an injury, the congruity of the knee is no longer present, and therefore it scuffs the cartilage of the knee. The end of the bones are very shiny, and that's called hyaline cartilage. And the reason they are is to reduce friction, so when you bend and straighten your knee out, there is no friction. But once you have an injury, you damage these cartilages, and that starts the arthritis process. Now, moving on to problems that can lead to a total knee or a knee injury are, of course, the wear and tear of the knee. Injuries, as I mentioned, and I just explained what my injury was. Rheumatoid arthritis, osteoarthritis, and infections. Once again, the congruity of the knee is a must. If we're going to not have pain and we're going to enjoy our activities such as ambulation, bicycling, riding, playing golf, if the knee congruity is good, we're going to feel good. But once they're damaged, then there's a progression, and usually it's the osteoarthritis. When is it time to replace a knee? Okay, let's see here. Well, you know, it's really, when people come to see me in my office, you know, I usually tell them, does your knee pain affect your activities of daily living? And if they say yes, does it affect your sleep pattern? Does it keep you up? These are all things that are signs of some sort of knee injury. Now, is the knee injury a meniscal tear, which can be repaired arthroscopically? Or we get x-rays, and the x-rays demonstrate bone-on-bone opposition, then you know the congruity of the knee is no longer present. And therefore, you're going to have pain. And the only way, once you go bone on bone, is to alleviate this pain and discomfort, you have to do a resurfacing of the knee joint. And that's what a total knee is resurfacing of a joint, okay? What, you know, frequent swelling, but really the big thing is that you're ambulating, and you're limping, and it affects your activities of daily living, and you're really not having fun. So you come to see the orthopedic surgeon, a standing x-rays and other x-rays we look at to see the severity of your osteoarthritis. And then we also can get an MRI to see if the soft tissue of the knee is affected. Maybe it's just a meniscal tear and you don't need a knee replacement. So those are the things that we do first. Now, some of the conservative treatment, of course, you should have conservative treatment. And number one is the non-steroidal anti-inflammatory medications, your ibuprofen, your naproxen, your Aleve, those kind of things. Because arthritis can give you inflammation, inflammation can give you pain. So this is the first line of defense, is your non-steroidal anti-inflammatory medication. But again, you have to be careful, because if you have stomach problems, the non-steroidal anti-inflammatory medications can make that situation worse. It can give you a stomach ulcer. Or if you have kidney problems, it can ruin your kidneys if you take too many of these non-steroidal anti-inflammatory medications. That's why it's important that you talk to your primary medical doctor or your orthopedic surgeon and say, well, I really can't take these medicines because they are causing more issues for me than they are helping. So there are other things. Physical therapy can be of some benefit, just to stay active. The others are joint injections. You know, we have hyaluronic acid injections, which is a substance that lubricates the joint. So again, to decrease that friction, because now, you know, the knee has osteoarthritis. So now when it bends and extends, there's an increase in friction because the articular surface is not as smooth. Therefore, the hyaluronic acid injections can be of benefit because they lubricate the joint. But again, this needs to be approved through your insurance company because these injections can be rather expensive. The other is cortisone injection. We've been using cortisone injections for 100 years for joint pain. And what that does is it decreases inflammation. Inflammation is what causes pain. So we can inject the knee and people will come back and they'll say, oh, this is a miracle. I have no pain. But depending on the severity of the osteoarthritis will determine the length of how long that injection is going to last. The worse the arthritis, the injection may only work for 2 weeks. Or if the arthritis is mild, it could work for 6 months. But the other aspect of cortisone injections, they can only be done so many times because they can destroy the soft tissue inside the knee. So we want to be careful with that. So of course, we always try the first line is conservative treatment, physical therapy, injections, non-steroidal anti-inflammatory medications. And if that doesn't work, well, then we need to plan for a knee replacement, okay? So for a knee replacement, the key is that number one is that a good joint be put into place. And number two is the big issue is physical therapy. You got to be able to do physical therapy. So it's always a good idea if you're not having too much pain that you sort of get in shape. In other words, usually when I see my patients and I know they need a knee replacement, I will probably send them to physical therapy just so we can strengthen the muscles around the knee so they have a better outcome at the end of, after we do the knee replacement. So, and then also what we need to do in the office if we're planning to do a knee replacement is, are you going to have physical therapy as an outpatient? Or are they going to come to your house to do physical therapy? And the other issue too is there are, I know the hospital has programs where if you're going to have a knee replacement, you go to a class and they tell you about what to expect during this procedure. And that's always a great idea because now you know what you're getting into, okay? So those are all good advices. Now, what happens during surgery? Okay, I brought a knee replacement here that I'd like to show you on exactly what we do. We make a midline, of course, you're under anesthesia. You're not feeling anything, okay? And so what we do, the first thing is, we gotta remember, there's skin over here, over my model here. So we make a midline incision, which usually extends anywhere from 10 to 12 centimeters, okay? And so in other words, it's about this long, the incision, okay? So then we do subcutaneous dissection around it, and then we got the capsule. The capsule goes all around the knee. So what do? We split the tendon right here in the center, and then we leave a little cuff. We have to leave a little cuff because I gotta reattach everything that I took off. So I make a midline incision, do what we call a para-arthrotomy over by the medial aspect of the inside part of the patella, and then what we do is we flip the patella, and the patella has arthritis underneath. So what we do is we measure it, and then we cut it, and then we put a button, a new button, so it can articulate with the new articular surface of the femur. If we did not do that, the bone is softer than the metal, and that would create an issue down the road. So that's why we always put a button underneath the patella. So now what do we do with the femur? So what we do is we make these cuts off a guide. We don't freehand this. There's a guide that we put on this to make these cuts so it can accommodate a new surface of the femur. So the femur is done now. And these ligaments on the side, they are not touched. Okay, we cannot touch those because that's going to provide stability for our knee replacement. So now what do? We go to the tibia. The tibia has articular cartilage, is all messed up. That's the arthritis. So what do? We have a guide to cut this, and then we put a a metal spacer right here, the tibial component, and all these things are cemented in with methyl methacrylate, so they won't come off, okay? So now, after we've done that, then we put a plastic spacer in between, so you have the coefficient of friction has been reduced, and now the knee works just like it's supposed to, without pain and discomfort, okay? So, and this is all done in the operating room, this different sizes, and we have trials for all this. So we trial everything, and then which one ever fits the best and gives the best congruity and gives the best stability, both in flexion and extension, is the prosthesis size that we use. And usually this takes anywhere from 60 minutes to about 90 minutes. Okay, just depending on how much work needed to be done with the arthritic knee. So that's what happens in the operating room. Now I'm going to show you a patient who had very severe osteoarthritis. Okay, and as you can see, the right knee is bone on bone, and it's subluxed to the inside. And this person has a pretty significant bow leg, or varus deformity is a bow leg. And so this particular individual, in my opinion, waited a little bit too long. Okay, as you can see, the knee joint is completely destroyed. So let's see what it looks like after. There it is. It's been restored to normal alignment. The patient has been restored to normal activities, and better yet, no pain. The pain is the reason why anyone should have a knee replacement if they are bone on bone or close to bone on bone. And sure enough, they are very successful. There's about 600,000 of these joints that are done on a yearly basis in the United States. And the success rate is anywhere from 90 to 95%, and they last anywhere from 15 to 20 years. And it is life-changing because, once again, it restores your activity and it decreases your pain. You have no more pain that you had on a daily basis. You don't have to take your non-steroidal anti-inflammatory medications that could be causing other issues in your body. The advice would be if the activities of daily living are compromised and pain, you should not wait. You should do these procedures as quickly as possible, as long as you are medically stable to undergo the procedure. Well, immediately following the surgery, it's funny you're asking that question. I just did a knee replacement yesterday. I just saw the gentleman, and he's sitting at bedside, and he's got very little pain, but you can have pain, okay? And I'm talking from experience also. I had my knee replaced about 14, 15 months ago, and I had pain. It was tolerable, but it was painful for about, I would say, 2 weeks. Well, you're walking post-operative day 1, whether you like it or not. That's our protocol. And so I would say that, the knee, in about 6 weeks, most of your pain will have subsided, and you're walking pretty decent in 6 weeks. But it takes about 3 months, I would say, before it feels completely normal. Great question. That is, yes, yes, if you're going to use a walker, you're going to, and you're going to put weight on your knee, but you're not going to want to because it does hurt. So that means that you're going to increase the amount of weight that you're putting on your upper extremities. So yes, if you can, before a knee replacement, maybe you may want to do some light weights and get your upper body strength a little bit better. And I would not recommend crutches. Walker is a little bit more stable. Great question. Okay, so in your house, you're going to need a walker, an elevated toilet seat would be a good thing initially, and rugs. Okay, any throw rugs, fold them up and get rid of them. Okay, because we don't want you to trip with your walker, because it's your gait's going to be off for a little bit. So that's what I would do. And of course, home health agency that's going to be coming out, or are you going to go to physical therapy as an outpatient? Those kind of things. And then also, besides a walker, you want to migrate to a cane. Well, playing golf is good. Riding bicycle is good. You can play some pickleball, okay? But, try, contact sports, basketball, anything that causes a lot of pivoting, I would discourage you from, okay? Because remember, when we do your knee replacement, we put a new articular cartilage, which is this is high molecular polyethylene. So what happens is the more you use it, there is some friction that occurs. This wears down, and you may need another, you may need another surgery to have the high molecular polyethylene replaced. So that's why, when we do total knees and things like that, we like to do them in people that are, 50 and older, because these things, they can last up to 30 years, but, the average is 15 to 25, so you don't have to do another surgery down the road. You can horseback ride, play golf, maybe some pickleball, and maybe some, pool. I don't know what, your activities are, but, let's be practical. If you run on it, you can run on it, but you're going to wear down the poly, and then you're going to be back in the OR to get the poly replaced. Oh, absolutely. In 6 months, you should be doing, you should be feeling pretty decent. At least 90% of your activities you're going to be able to do 90% of your activities in 6 months. Okay, on a long car ride, any long car ride, people cramp up. The idea is, there's lots of rest stations in this country that you can pull over, get out for 10, 15 minutes, and then go back on the road. So that's what I would recommend. Okay, the success rate for knee surgeries right now is between 90 and 95%. So what can you do so you can have a successful one also? Physical therapy. You have to go to physical therapy. You have to work through the pain that you're going to have after you have your knee replacement, and you will do well. But it's going to take work. And if you want a successful knee, do the work, you will have a successful knee as long as the implant was placed the correct way.